Okay, so on let's start with chromosome 3. So before chromosome 3 comes chromosome 2, where you have the ALK oncogene, and this is for three cancers. You have adenocarcinoma lung, we have inflammatory myofibromatosis cancer, and there is one more, there is um, anaplastic large cell carcinoma. So three tumors, these are oncogenes, anaplastic large cell carcinoma. Alright, next comes chromosome 3, where you have von Hippel-Lindau disease and renal cell carcinoma. So von Hippel-Lindau is contains RCC, which is clear cell type, and you have cerebellar hemangiomas, right? So cerebellar lesions and cerebellar hemangiomas, that is the symptoms in von Hippel-Lindau disease. Now talking about everything RCC. So starting with the TNM classification for RCC, we'll write it here. So T1, T2 is going to be less than 7 and more than 7 centimeters, but limited to the kidneys, right? T3 is going to be invading the major veins around the kidney and the adrenal glands, but not breaching the Gerota's fascia. Whereas if it does go beyond the Gerota's fascia, then it is T4, right? How are we going to manage RCC? If it is less than 7 centimeters or if it is limited to the poles, then we are going to do a heminephrectomy, right? Otherwise, in all other conditions, we are going to do for a radical nephrectomy. So radical nephrectomy, what are the structures we are going to remove? We are going to remove the kidney, the para-aortic lymph nodes, along with the adrenal glands, right? Talking about the adrenal glands, this is going really tangential, but one important thing we want to remember about the adrenal glands is the adrenal cortex is derived from the intermediate mesoderm, whereas the medulla is derived from the neural crest cells, right? So this was about RCC. Again, coming to the histological subtypes of RCC. So the first is the clear cell type, which is the most common type, which is, like we discussed already, associated with von Hippel, and it is also associated with tuberous sclerosis. So we'll talk about tuberous sclerosis in detail in a while. And it is associated with deletion 3p and deletion 6p, right? The second type, and this one originates from the proximal convoluted tubule. The second is the papillary type, which again develops from PCT or DCT, right? It contains it, or it shows Samoma bodies because it is papillary type, and the micropapillary type is what is associated with long-term dialysis. The third type is the chromophobe type, right? And the chromophobe type has the best prognosis. It originates from the intercalated cells of the collecting duct, and there is loss of multiple chromosomes. It is associated with Birt-Hogg-Dube syndrome, and it shows plant-like cells on HPE, which are cytokeratin positive. The fourth type is the collecting duct type, which has a poor prognosis or the worst prognosis, right? Originates obviously from the collecting tubules and associated with deletion 1q. And the last type is the medullary type, which is associated with sickle cell anemia majorly, right? And again, it has a poor prognosis, but the worst prognosis is collecting duct type. So this was all things RCC. Now let's talk very quickly about tuberous sclerosis as well. So what is it also known as? It is also known as Boneville disease. It is autosomal dominant, right? And it shows something called the Vogt's triad. So the Vogt's triad is going to be mental retardation, seizures, along with adenoma sebaceum, right? And what are the other skin lesions that you see? You see ash leaf macules, we see periungual fibromas and keratosis, confetti skin lesions, shagreen patch, etc., right? What is the cause for it? So there is a hamartin and tuberin gene present on chromosome 9 and 16. So we can write it here itself. 9 is TSC1, which is hamartin, and TSC2, is tuberin, okay, which is on chromosome 16. So these two genes are present. Now what are the various findings? So in the kidneys, what you see is myolipomas, angiomyolipomas, okay, which on gross will give you a stellate star appearance, right? In the lungs, what it will show is your lymphangiomyomatosis, right? In the heart, in children, it will show rhabdomyomatosis, which on HPE is going to show you spider cells, and in adults it will show you myxomas, which again on HPE will show you lipidic cells. All right, what is the management going to be? Management is going to be with mTOR inhibitors like sirolimus, everolimus, and the West syndrome, which is infantile seizures, is also associated with tuberous sclerosis. Treatment for that is going to be vigabatrin, right? Otherwise, it is ACTH, but when tuberous sclerosis is associated, the treatment is vigabatrin, and vigabatrin has visual side effects, right? Because it has VI in it. So that was all things RCC we've covered. The next thing we need to know is your autosomal dominant polycystic kidney disease. So it has two genes. You have PKD2 and PKD1. PKD2 is on chromosome 4 and PKD1 is on chromosome 16 again, along with the TSC2, which is tuberin, okay, along with the gene for tuberin. When it comes to ADPKD, there's one thing we need to remember, which is called the Ravine's criteria for the management of ADPKD. So one thing you also want to remember was a separate MCQ. Saccular aneurysms are most common type of aneurysms associated with ADPKD, and the Ravine's criteria is according to the age, how many cysts do you need in the kidneys to diagnose ADPKD, right? So 15 to 39, from 40 to 59, and more than equal to 60. Remember 3, 2 and 4, more than equal to, but this is unilateral or bilateral, whereas this is in each kidney. That is how you remember, right? And like we discussed already, you have PKD1 gene and 2 gene. One is on chromosome 16, 2 is on chromosome 4. So that is about everything about ADPKD that we need to know. Achondroplasia again is remember that all of these are autosomal dominant disorders, right? Huntington's, achondroplasia, and autosomal dominant PKD. Achondroplasia is basically the most common. I'll write it here. Achondroplasia is the most common cause of disproportionate short stature, right? So there is a problem with the chondroblasts. So enchondral calcification is what is defective in achondroplasia. So there will be findings of trident hand and champagne glass pelvis. These are all findings of achondroplasia, right? And the disproportionate short stature is the most common cause. Usually it is easy to pick up from the diagnosis, and it's autosomal dominant. Huntington's disease, so remember, let's finish off all trinucleotide repeats in one place. So you have Huntington's disease, we have Friedreich's ataxia, we have Fragile X, right? And there is also dystrophy, muscular dystrophy type 1, which they haven't mentioned here. So let's start with Huntington's disease. So Huntington's is going to be CAG, trinucleotide repeats. It is autosomal dominant. What are the findings? There will be reduced dopamine and caudate atrophy, right? Caudate lobe atrophy of the brain, right? So these are going to be the findings in Huntington's disease. There's going to be dementia, chorea, movement disorders, etc. All right. Friedreich's ataxia is going to be GAA, trinucleotide repeats. It's on chromosome 9 along with the Hamartin gene, right? And there is going to be obviously ataxia along with it. Fragile X is going to be macroorchidism. That's on chromosome X, obviously. Okay, the trinucleotide repeat is going to be CGG, can grow gonads. okay, because there's going to be mental retardation, and this is going to be macroorchidism, etc. All right, so that is Fragile X syndrome. Fragile X is the second most common genetic cause of intellectual disability following Down syndrome. This is the most common cause genetic of intellectual disability, right? Down syndrome. So Downs, let's do it again. Trisomy 21, right? Down syndrome, we know there is duodenal atresia. We know there is, okay, which is going to show a double bubble sign. There is going to be Hirschsprung disease, right? Then there is going to be prominent epicanthal fold. There is going to be a saddle gap, and what else? It is associated with Alzheimer's. It is associated with acute leukemias, both myeloid and lymphoid, right? Especially AML M7. What else? So like we said, there's going to be intellectual disability. Along with that, in the quadruple screening, there will be increased beta HCG and increased inhibin A. These are going to be the findings in Downs. So this is all Down syndrome. What all will you find? Edwards syndrome, again, Edwards and Patau, let's do them together. So Edwards syndrome is trisomy 18, Patau syndrome is trisomy 13. Edwards, on quadruple screening, everything will be low. Everything is low. Your PAP A, inhibin A, estriol, beta HCG, everything is low. So how we remember is, when you turn 18, you become old like an Edward uncle who is depressed and low all the time. All right. Patau syndrome is 13. So here you have reduced beta HCG and reduced PAP A. Right. These are the findings. Otherwise, both we will have rocker bottom feet. Right, Edwards syndrome has something called a strawberry skull. Okay, there's going to be microcephaly, etc. So all your trinucleotide repeats are done. All right. The fourth trinucleotide repeat that they've not mentioned here was actually muscular dystrophy type 1, right? And what is important is the trinucleotide repeat over here is cannot terminate grip, CTG, right? And the other finding is going to be cataracts. So there's going to be cataracts, there's going to be tone defects. So and cataract is going to be Christmas tree cataract, right? Christmas tree cataract, right? And other problems. So that is muscular dystrophy. That is the next trinucleotide repeat. Coming now to Credo chat. So Credo chat is basically cat-like cry. It is microdeletion in 5p, small arm of chromosome P. FAP, familial adenomatous polyposis, is because of APC gene mutation, right? And it leads to colon cancers. How? There is an AK53. So APC followed by KRAS followed by P53 gene mutations, one after the other, which leads to colorectal carcinoma, also associated with pancreatic carcinoma, right? P53, remember, is present on chromosome 17q. 17p, right? And it is also associated with Lee-Fromeny syndrome. So this was familial adenomatous polyposis. Next, coming to two diseases which we can discuss and finish off together. We have hemochromatosis, which is HFE, which is present on 6p. Okay. And there is the short arm of chromosome P, along with Wilson's disease, which is present on chromosome 13 along with Patau. So let's talk about the difference. The major pathophysiology behind hemochromatosis is going to be that it's usually presents in 40s to 60s or older age group, where HFE gene means it leads to iron metabolism defects and increased accumulation of iron. So this iron is going to get accumulated in various organs, and it's going to cause diabetes mellitus. It's going to cause, this is hemochromatosis we're talking about, it's going to cause bronze skin appearance, and arthritis, but especially small joint arthritis. right? As compared to, we are going to compare it with Wilson's. In Wilson's, the defect is that ATP7B gene is defective, right? We have ATP7B gene which is defective, and this leads to copper not being accumulated within ceruloplasmin. Ceruloplasmin is a carrier, so Wilson's copper is not being it's not going with ceruloplasmin, so the level of bound copper to ceruloplasmin reduces, the level of ceruloplasmin itself also reduces, and excretion of urinary copper excretion will increase. All right, so this is going to be one of the screening tests. Along with that, because the free copper concentration increases, copper gets deposited in the brain, in the liver, etc. So the gold standard is going to be a biopsy of the liver, where we are going to stain it with rhodonine and rubianic acid, which are the stains for copper, and we are going to see excessive copper deposition within the liver, within the brain. So we are going to have neurological signs and symptoms like um, wing beating tremors, right? Another classical finding is going to be Kayser-Fleischner ring around the iris, around the cornea, around the cornea. This is because of copper deposition in the Descemet's membrane. So when it comes to ophthal, we need to remember Descemet's membrane, two things are there. One is KF ring, obviously, and the other thing is also Habs striae. The Habs striae that we see in Buphthalmos, right? They are also a break in the Descemet's membrane. So this is just a separate point. Otherwise, Wilson's disease, this is what we see. The management for Wilson's disease, so also neurological involvement is 100% there. If there is a KF ring, that means there is neurological involvement in Wilson's disease. All right. Otherwise, we'll also see other these things, and the arthritis here that we will see as compared to hemochromatosis is going to be a large joint arthritis generally. All right. So this is the difference between Wilson's and hemochromatosis. Liver cirrhosis is again a very common manifestation of Wilson's disease. Management is going to be D-penicillamine, right? Or you can also have zinc, because zinc inhibits the absorption of copper from the GIT, and trientine. These are all drugs that will chelate, D-penicillamine especially chelates copper and increases the urinary excretion of copper. So remember, normally in Wilson's disease, anyways, urinary excretion of copper is increased. When you are giving chelators like D-penicillamine, you're further increasing the urinary excretion of copper. So these are all the questions they can possibly ask you from Wilson's, Wilson disease and hemochromatosis. Now coming back, let's talk about Williams syndrome. So Williams syndrome is a defect again. So that was chromosome 7. Okay, let's finish off others actually. So 6p, hemochromatosis is one gene. There is another gene for MHC, major histocompatibility, right, class 1 and 2, or HLA antigen. This is also present on 6p, and even type 1 diabetes mellitus, the gene is present on chromosome 6. I'm not sure if it is P or Q, but it's chromosome 6. So let's finish off major histocompatibility, or MHC. All right, so you have MHC, or major histocompatibility antigen, or HLA antigen. You have two types, type 1 and type 2. All right, type 1 is coded by HLA A, B and C, whereas type 2 is coded by DQ, DR and one more, right? DQ, DP, DQ, DR, sorry. Right? Now, class 1, the peptide binding domain is alpha 1, alpha 2, whereas in class 2 it is alpha 1, beta 1. All right. Now what it does, what is the function, is that class 1 is actually present on all nucleated cells, and it recognizes endogenous antigens and processes them via the cytosolic pathway and presents them to CD8 positive T cells, as compared to MHC class 2 is present on antigen presenting cells and the activated T cells, right? It recognizes exogenous antigens and it meta processes them via the endocytic pathway and then presents them to CD4 positive T cells. So that is the major difference between MHC class 1 and class 2. Is that clear? So the endogenous antigen binds to alpha 1, alpha 2 of MHC class 1, which is present on all nucleated cells. It will process it via the cytosolic pathway and present it to CD8 positive T cells, right? As compared to the exogenous antigen will bind to alpha 1 beta 1 of MHC class 2, which is present on APCs and activated T cells, which will process them via endocytic pathway and present them to CD4 T cells. So that was all about antigen about MHCs. Coming now to Williams syndrome. So Williams syndrome is something, so there is something called the elastin gene, all right, which is present on chromosome 7, right? And there is a defect in the formation of this elastin protein basically. So what are the manifestations? There will be mental retardation, there will be hypercalcemia. This is because of primary hyperparathyroidism. There is going to be supravalvular aortic stenosis, which is common, right? And there's going to be extreme friendliness to strangers, etc. These are the findings of Williams syndrome. So what is the major catch? Is going to be mental retardation, hypercalcemia, aortic stenosis. These are the buzzwords for Williams syndrome. So this is Williams syndrome. Now, ironically, for this elastin protein, the scaffold that is present or that you require within the extracellular matrix is fibrillin. Have you heard of the word fibrillin? It's present on chromosome 15, and a defect in fibrillin, surprise, is going to lead to Marfan's. So where is chromosome 15? Here. So 15, Marfan syndrome, right? What are the findings that we will have in Marfan's? Is going to be easy. It's going to be superior temporal lens dislocation. There is going to be mitral valve prolapse, aortic necrosis. There's going to be hypermobility of the joints, etc. So that was Marfan syndrome, right? Coming next to, retinoblastoma is next. Retinoblastoma is going to be, the buzzwords are going to be flex. So on histopath, what we are going to see is Flexner, Wintersteiner, pseudo-rosettes. Let's talk about retinoblastoma. There's going to be flex on HPE. We're going to see Flexner, Wintersteiner, pseudo-rosette. They are small round blue cell tumors, also associated with osteosarcoma. The primary mode of spread is going to be direct spread or via the optic nerve. This is one of the causes of leukocoria or the white reflex in children, and the treatment is going to be with enucleation along with chemotherapy, which with carboplatin, etoposide, and vincristine. So this was everything retinoblastoma. Come back to chromosome 13. We also have BRCA2. So let's talk about BRCA1 and BRCA2 together. So we have BRCA2 on chromosome 13 and BRCA1 on chromosome 17. Both are present on the long arm. So we have BRCA1 on 17q, BRCA2 on 13q. Majorly, BRCA2 is what is associated with male breast carcinoma, BRCA1 is what is associated with female breast carcinoma, also other carcinomas like ovarian carcinoma. Major differences is that BRCA1 is going to be triple negative and it's going to be poorly differentiated. In other words, it is going to be high grade carcinoma, and it is also associated with medullary thyroid carcinoma, as compared to BRCA2, which is going to be ER/PR positive, so it is going to be well differentiated or low grade carcinoma with a relatively better prognosis, and it is also said to be associated with Fanconi's anemia, right? So this was BRCA1 and BRCA2, right, present on 17q and 13q chromosomes. So we're done with BRCA. Coming now to the two imprinting disorders. There is we have Prader-Willi syndrome and Angelman syndrome, right? So let's understand the concept of imprinting. So imprinting basically means there is silencing or methylation. So there is Prader-Willi. They are both related with chromosome 15 along with Marfan's, right? So there is Prader-Willi and there is Angelman. So there are two alleles for any gene. When one of them is silenced, your work is going to depend on this one other gene. When there is a deletion or a mutation in the other gene or in the other allele, that is what leads to these disorders. Therefore, Prader-Willi is paternal deletion or mutation, whereas Angelman is maternal deletion or mutation, right? So I hope we realize imprinting is of the other. So in Prader-Willi, there is silencing of the maternal allele, and here it is silencing of the paternal allele, but that is not the major problem. The disease is manifesting because of the deletion or the mutation and not because of the imprinting per se. All right, so what are the clinical features? Prader-Willi, remember, this very fat, so there is going to be hyperphagia, obesity and hypogonadism. Angelman is going to be happy puppy, it's called a happy puppy faces or something like that, okay, with mental retardation. All right, so that was Angelman and Prader-Willi imprinting syndromes, again associated with chromosome 15. All right, chromosome 16, we have now the alpha globin gene defects or the alpha thalassemias also along with PKD1. So let's finish off all thalassemias. So remember that in the adult, the major hemoglobin is HbA, which contains alpha 2, beta 2 globin genes, right? The alpha 2, for the alpha globin gene, we have 4 alleles and they are all present on chromosome 16 like we just saw, whereas the beta 2 has 2 alleles and they are present on chromosome 11, right? So I don't know, did we just see, I think we missed this over here. Beta thalassemia 11, chromosome 11. So alpha is 16 and beta is chromosome 11. All right, now the most common cause, so whenever there is a defect, it's going to cause alpha thalassemia here, and whenever there's a defect here, it's going to cause beta thalassemia, right? Common causes over here are going to be gene deletion straight up, right? And here it is going to be a point mutation which either leads to splicing or termination. So when it is splicing, we write it as beta plus with a splicing mutation, or beta 0 with a termination. So what are the various possibilities? Here you can have gene deletion, so you can have alpha thalassemia minima, you can have alpha thalassemia minor, which can be either trans or it can be cis, and this has a poorer prognosis. Then you can have alpha thalassemia intermedia with 3 gene deletions. So this is also called the HBH disease. Okay, it has something called the golf ball inclusion bodies, which are going to be seen on supravital staining. And finally, you have the Bart disease where all 4 are mutated. So this is going to be gamma 4, and here this is incompatible with life. All right. For beta thalassemia, I'll write it here. Beta thalassemia, you can have either one gene mutated like this. This is going to be beta thalassemia minor, which increased HbA2. So A2 is going to be alpha 2 delta 2, right? This is another type of hemoglobin. The second is beta thalassemia intermedia, where you have both genes mutated. Okay. And the third is beta thalassemia major, where you have one splicing and one termination mutation. Okay, here there is going to be increased hemoglobin F by at least 95%. In intermedia, you have increased by at least 50%, right? This is also what is called Cooley's anemia, right? Because there is hemolysis and therefore there is extramedullary hematopoiesis, which leads to Cooley's anemia. So there's something going called the chipmunk facies that we will have because of extramedullary hematopoiesis, right? How is the screening going to be like with thalassemia? We can use high performance liquid chromatography, or we have something called the Nestrov test. Diagnosis is going to be with globin gene sequencing always, right? We want to sequence the globin gene. Management, one is we do recurrent blood transfusions, but the major side effect of it is going to be iron overload. So for that iron overload treatment, we are going to give desferrioxamine. But the definitive therapeutic management is going to be hematopoietic stem cell transplant. Now, quickly talking about Nestrov test, the idea behind the test is that osmotic fragility reduces in thalassemia. So you take 2 test tubes, and if there is lysis of blood, okay, it means that the 2 lines, basically you place the test tubes against a paper, okay, and if you can see the 2 lines, if here, like here, you can see through the test tube, that means there is hemolysis has occurred, right? So it can see, but when when hemolysis has not occurred, that means there is still lysis has not occurred and the cells are intact. It means you cannot see the lines of the paper behind it, and this is what is seen in thalassemia. So if you see, this is the graph, this is the percentage of saline, and this is percentage of hemolysis. This is how the normal, it's the other way around. This is how the normal osmotic fragility curve is like. So basically what is happening is, this is the RBC and you're putting it in saline, okay? For saline, for water to come inside and the cell to swell and then eventually burst and lyse, what is the concentration? So the more water you need outside, it's like fresh water versus seawater drowning. So if you need more water and more dilution of the saline for it to lyse, it means your osmotic fragility has reduced. There is a leftward curve, right? And this is what is seen in conditions like thalassemia, in sickle cell anemia, iron deficiency anemia, whereas it increases, or there is a rightward shift in conditions like hereditary spherocytosis, autoimmune spherocytosis, and burns. And so that was the concept of osmotic fragility. Since we are on the topic, let's discuss also oxygen hemoglobin dissociation curve, which is a curve like this. Here you have percentage of oxygen, here you have percentage saturation of oxygen. Alright. So always remember, left leaches oxygen. That means the affinity for oxygen increases. Alright. And this is going to be seen in alkalosis, L for left. So alkalosis, which is increased pH. What else? Whenever there is reduced temperature, reduced 2,3 BPG, everything which reduces is on the left. Alright, along with reduced PCO2, there is carboxyhemoglobin, methemoglobin, fetal hemoglobin also. All of these have increased affinity and they will not release oxygen, as compared to rightward shift. Right releases oxygen, so affinity for oxygen reduces. This occurs with increased 2,3 BPG, increased temperature. It occurs with exercise. These are all the conditions where you need more oxygen to be delivered. So there's going to be increased PCO2. All of these conditions, anemias, all of these conditions are when you need more oxygen in the tissues and you want hemoglobin to release more oxygen. Therefore, there's going to be a rightward shift in the hemoglobin oxygen dissociation curve. Alright, so that was it. A lot of tangentiality, but I hope this is helping. Next, now let's talk about the next. So we did 11, chromosome 11 we've forgotten. I think Wilms tumor, it's easy, it's chromosome 11. Beta globin gene defects, because beta globin is present on chromosome 11, like beta thalassemias, right? We did chromosome 15, Prader-Willi, Angelman imprinting syndromes, Marfan syndrome, fibrillin gene defect. Marfan's is again autosomal dominant. All right. 16 is you have your tuberin gene for tuberous sclerosis, ADPKD, alpha gene defects. 17 is going to be neurofibromatosis type 1, which is a neurocutaneous disorder. So remember, all neurocutaneous disorders are autosomal dominant, except Sturge-Weber, which is sporadic. All right. Now quickly, in NF type 1 is going to have features like pheochromocytoma, like cafe au lait macules, leash nodules on the iris. And remember, cafe au lait of NF1 or NF2 for that matter, the cafe au lait macules, we will also have it in McCune-Albright. So the difference between the two, okay, McCune-Albright, which is a GNAS mutation, right? GQ alpha mutation. This is McCune-Albright with precocious puberty, cafe au lait, and fibrous dysplasia. So the cafe au lait and McCune-Albright are going to be irregular. They are going to be unilateral. They do not cross the midline, as compared to in NF1, the cafe au lait are going to be regular. They are going to have smooth margins, and they will cross the midline, and they will be present on both sides of the body. They will be bilateral. That was NF type 1. We've done BRCA1, Downs, Edwards, we've done. 22 has NF type 2. Alright, NF type 2, just remember there is vestibular schwannomas. And two important things you want to remember is the best investigation for vestibular schwannoma or audiometric schwannoma is actually MRI. But the best audiometric investigation is going to be BERA, brain evoked response audiometer. Alright. Next, coming to DiGeorge syndrome. So DiGeorge, let's talk about DiGeorge syndrome. It is basically a defect in the third and the fourth pharyngeal arches, and then we know the mnemonic catch 22. So you have cleft lip and palate, you have atypical facies, thymic aplasia, hypocalcemia because of parathyroid dysplasia, and this is cardiac anomalies and hypocalcemia. So that is DiGeorge syndrome 22q11 due to pharyngeal arch 3 and 4th defect. Alright, Fragile X, we've done CGG, macroorchidism, second most common cause of genetic intellectual disability. Talking now about X-linked A-gamma globulinemia, which is also called Bruton's A-gamma globulinemia. Remember, this is X-linked recessive, just like G6PD deficiency, right? And the defect over here is that there is a defect in BTK, which is a tyrosine kinase protein, which where because of which there is no B cell maturation. And we know the function of B cell is to form gamma globulins, right? Immunoglobulins. So when this does not occur, there is going to be recurrent bacterial and enterococcal infections in the child, but this will be beyond 6 months. Why? Because up till 6 months, the maternal IgG is going to cross the placenta and provide immunity to the child. So this was everything about X-linked A-gamma globulinemia. And the last thing that we need to know is Klinefelter's. We know it is trisomy. You have something called the bar body. Bar body means extra X chromosome, and more the number of bar bodies, more is the intellectual disability that is going to be seen with Klinefelter syndrome. There will be eunuchoid features with female kind of distribution along with of hair, along with gynecomasia. There's going to be tall stature, infertility. So majorly hypogonadism is a cause of infertility, and during evaluation of infertility is how Klinefelters can be detected as well. So this was very quickly about a lot of chromosomes that we've discussed. If I hope I've not missed out on anything. There are other couple of chromosomes. You can do chromosome 10 also has RET proto-oncogene, which they haven't mentioned here. We can write it down. Chromosome 10 has RET proto-oncogene, which is associated with medullary carcinoma, thyroid, and MEN2 syndrome. And it also has P10. This is a tumor suppressor gene, right? And P10 loss of function mutation leads to the Cowden syndrome, right? Cowden syndrome, if you remember, was endometrial carcinoma, GI carcinoma, and breast carcinoma. This is the triad of Cowden syndrome. Okay, apart from them, I think we've covered most of the things. So that is